This video is all on liver pathology, and we said most of liver pathology comes from alcohol, right? Alcohol. And so we'll start with that first. Alcohol, if you remember from my biochem block, alcohol increases fat synthesis. And increased fat in your liver can damage your liver, but also when you metabolize alcohol, metabolism, it creates toxins like acetaldehyde, which is never good. It creates free radicals, which can damage your liver. So all these things can damage your liver. So alcohol is one of the main causes of liver damage, and it comes in stages. If you drink occasionally or a little bit, then you won't see too much damage, but you will see this increased fat synthesis, so we call it alcoholic or hepatic steatosis. So it's just a little bit of fatty change. You'll see these little fat bubbles show up in your liver. And if you stop drinking, then it kind of goes away. It's reversible. So, reversible. But if you keep drinking and your liver keeps metabolizing all that alcohol, then all that toxins, all those free radicals will eventually cause damage and inflammation to your liver. And we call that stage alcoholic hepatitis, itis meaning inflammation. All right, so you're starting to damage your liver. You're starting to destroy your cells, kill your cells, and you'll actually start to see necrosis. You'll even see something called Mallory bodies. What are Mallory bodies? Mallory bodies, here's your cell, here's your nucleus. Mallory bodies occur when your cytoskeleton gets destroyed. Your intermediate filament gets destroyed, and you'll actually be able to see it on the cell, and we call those Mallory bodies. So I'll write cytoskeleton destruction. And if you keep on drinking, then eventually you'll have alcoholic cirrhosis. So you'll start to create that fibrotic tissue, that scar tissue, that cirrhosis. And your liver will start to get nodular, get shrunken, get shriveled up, start to lose its function. Now, some key points, hopefully you remember from our last video, what zone of your liver does alcohol affect? That'd be zone 3. Zone 3. What are some lab findings you'd see in alcoholic cirrhosis? A lot of throwbacks from our last video. Hopefully you're paying attention. That's increased AST over ALT. Remember our little memory aid, toast? So you have increased AST. So that's all alcoholic related liver damage. Now you can have liver damage from non-alcoholic causes. You can have something called non-alcoholic fatty liver. So you get a fatty liver not from alcohol. How can you get that? Where does all that fat come from? Well, if you have metabolic syndrome, or if you're obese, metabolic syndrome or obesity, then those fatty infiltrates can go into your liver and cause fatty liver. Now, history will be totally different. The person will not be drinking. They will have a history of metabolic syndrome, diabetes, high blood pressure, all that stuff. And then they'll show a liver with a whole bunch of fat in it and ask you what's the problem. Do not pick alcohol because it's not a drinker. It's not alcoholic fatty liver. All right, what are the labs here? It'll be ALT over AST. All right, so the more liver specific damage. Now, since we're talking on things like toxins, let's talk about Reyes syndrome. Reyes syndrome occurs when a kid is suffering from a viral illness and is given aspirin. Reyes occurs when you give a kid aspirin. So, right, kid plus aspirin equals Reyes. And what happens? Well, the aspirin seems to affect the mitochondrial enzymes, and stops it from breaking down fat. We call breaking down fat beta oxidation. So it stops beta oxidation, and when you stop beta oxidation, then fat will build up. It seems to be a running theme here, a bunch of fatty change in your liver. So fat will build up and destroy your liver. So the history is very, very easy to recognize. There'll be a kid that was sick, like, I don't know, upper respiratory tract infection. Their ma gave them some medicine, some aspirin, and then all of a sudden they take a dive. All of a sudden they take a dive. All of a sudden they have hepatomegaly. All of a sudden their freaking liver enzymes are way off the chart. So AST's elevated, ALT's elevated. They have things like hypoglycemia, because we said your liver does gluconeogenesis. You knock out your liver, you can't do hypoglycemia. So they're comatose, they're having nausea, vomiting, all this stuff. Yeah, that's a dead giveaway for Reyes syndrome. All right, so don't give kids aspirin, all right? Don't give kids aspirin. You can look in the bottle of aspirin, so don't give it to kids. The only exception, there's a little trivia fact, a step fact. The only exception of the times you give a kid aspirin is Kawasaki's. That's that vasculitis. All right, the reason we give it is because if you don't give it, they might have coronary aneurysm, and so the risk benefit on that situation is greater. However, in general cases, don't give a kid aspirin, or you might give Reyes syndrome. Good? Good. Now, we finished off some general causes of liver damage. We're not going to really talk about hepatitis because that was more micro. So if you want to know about hepatitis, look at my micro videos. Now I want to talk about hereditary causes of liver damage. Hereditary liver disease. This is an inborn cause of liver damage, and the pathophys of all of these are the same. There's some sort of buildup of a toxic substance, buildup of a substance in your liver, and that causes liver damage. Equals damage. So suspect this in any young patient who doesn't drink. Doesn't drink and has cirrhosis. And you're thinking, how in the heck do you have cirrhosis if there's nothing wrong with you? You're just a perfectly normal young patient and all of a sudden they have cirrhosis. That's like a dead giveaway that there's some inborn problem with your liver. And the three main ones we're going to talk about is going to be alpha-1 antitrypsin deficiency. We're going to talk about Wilson's. And then lastly, we're going to talk about hemochromatosis. Now, alpha-1 antitrypsin is not a new topic, all right? It's not a new topic, and I want you to pause the video and tell me everything you know about alpha-1 antitrypsin. All right, so take a moment, pause the video, tell me everything you know about alpha-1 antitrypsin. I'm gonna give you some time, All right, I think that's good. If you said alpha-1 antitrypsin is made in the liver, goes to your lungs and stops neutrophilic elastase, that's not good enough. If you said it stops elastase, which otherwise we call it pan-acinar emphysema, and that's getting a little bit better. If you said, if you have a deficiency in this, it causes pan-acinar emphysema, and the lab findings are gonna be low alpha-1 antitrypsin, you're gonna have hyperinflated lungs, spirometry will show increased TLC and decreased FEV1 over FVC ratio, then we're getting somewhere, all right? That's how you have to think. You should be able to pull up all those facts immediately. All right, and if you're not to that point, that's okay. We still have a lot of videos and lectures to go over until you get to that point. But that's the point you have to get to if you really want mastery of the material, really want to get a good step score. All right, so alpha-1 antitrypsin is made in your liver, goes to your lungs, where it stops neutrophilic elastase. And if you have a deficiency in that, then you can't stop that elastase, and that elastase will destroy your lungs. You get pan-acinar emphysema. Pan-acinar emphysema. That's the easiest giveaway. So a young patient will have cirrhosis plus emphysema. That's alpha-1 antitrypsin deficiency. So a young patient comes in, has hyperinflated lungs. Their spirometry shows increased lung capacity, decreased FEV1 ratio. And then they might ask, what else are you gonna look for? You're gonna look for elevated like liver enzymes. You're gonna be looking for cirrhosis because that's not normal in a young patient. So they're trying to clue you in that, oh, maybe it's alpha-1 antitrypsin deficiency. Now, what causes the deficiency in the first place? Well, there's going to be a mutation in the alpha-1 antitrypsin gene, and you won't be able to make the protein normally. So you have a misfolded protein, and that misfolded protein can't leave your liver. And so it builds up in your liver, and destroys your liver. That's what causes your cirrhosis. And because it builds up in your liver and can't leave, that's what causes the deficiency. And you'll be able to see all that build up in your liver because it is past positive. One last factoid they want you to know is that they really like the genetics of alpha-1 antitrypsin deficiency because it's codominant. There's not a lot of things that are codominant. There's blood types that's codominant, but alpha-1 antitrypsin deficiency is also codominant. So codominant. The normal genotype is MM. So right, normal. The abnormal is ZZ, abnormal. But you can also have MZ, so you express both because it's codominant, and then the phenotype is somewhat variable. So that's MZ is both. All right, so just know it's codominant, past positive, cirrhosis and emphysema should be good. All right, Wilson's. Let's move on to Wilson's. Wilson's is a mutation in ATP7B, and that helps you excrete copper. You can't excrete copper, then copper builds up in your liver and you have liver damage. So how do you excrete copper? Well, copper can get excreted in your bile, or it can, this is a little copper molecule, all right? Or it can bind to some protein called ceruloplasmin. Ceruloplasmin. And it binds to that, and that can excrete it. If you have a mutation in this gene, then you can't excrete it. All right, so you can't excrete it in bile, and you won't be able to bind it to ceruloplasmin. So here's ceruloplasmin, and here is copper now free. Doesn't have to bind. And ceruloplasmin will leave the body all on its lonesome, and your body will look at that ceruloplasmin and say, what happened to your copper friend? That's not normal. And it'll actually destroy your ceruloplasmin. Your copper, being free, will leave and deposit everywhere. Copper will deposit everywhere. Copper will deposit in your brain, in your basal ganglia, and cause things like Parkinson's, cause things like dementia. You have so much copper it can actually deposit in your eyes and your cornea. We call those Kaiser-Fleischer rings. You can actually see the copper in your eyes. So if a young patient comes in with cirrhosis and Parkinson's or dementia, they're cluing you in on Wilson's. And then they might ask, all right, what's the next thing you might do? You might look at the eyes, look for those Kaiser-Fleischer rings, because even though they're very rare, they're very specific. If you see copper in the eyes, there's nothing else it can be, okay? So you can look for the eyes, or you might order some labs. What are some labs you can order? Well, labs, you're gonna see increased copper. That's the name of the game. In your blood, in your urine, everywhere. You might even see it on a liver biopsy, so it's everywhere. And you'll have decreased serum ceruloplasmin. Because remember, your body recognizes your free ceruloplasmin, so that's not normal, breaks it down. So you have decreased serum ceruloplasmin. How do you treat it? You can chelate that copper, which just means binds and get rid of, by D-penicillamine, or by triadenine or oral zinc, if you can't tolerate the above. That's Wilson's. Let's talk about hemochromatosis. Hemochromatosis is due to deposition of iron, aka hemosiderin. And we need iron. Iron's very important because it's found in our blood and a bunch of different places, but too much iron can cause free radicals via the Fenton reaction. So it can cause free radical damage and damage your body. It doesn't only damage your liver, that wouldn't make sense. It damages all over your body. So it can damage not only your liver, but it can also damage things like your pancreas. So you get diabetes, you can damage your joints, so you get arthritis. It can damage your heart, you get cardiomyopathy. But most important and probably the easiest thing to recognize is that it can deposit into your skin and turn your skin bronze. Skin bronzing. In real life, it's very hard to pick up. It's not kind of like golden bronze, which they kind of tell you in Mexico is very, very subtle, but that's not your worry, because in the question stem, they'll straight up tell you the skin's bronzing, or they might say the patient's wife told them, oh, they noticed my skin was bronzing. So it's a dead giveaway. So in the question stem will be very easy to recognize, and skin bronzing is a big, big giveaway. Now, what causes that increased iron in the first place? Well, you can acquire that iron if you need transfusions. So if you have sickle cell or if you have beta thal and you need constant blood transfusion to live, then you keep getting blood, and all that blood will eventually die and the iron will be released, and you have too much iron, you get hemochromatosis. You can have genetic, hereditary causes like mutations in C282Y or H63D. Unfortunately, I have been asked these, so you should actually know these. In the HFE gene. HFE literally stands for high iron. All right. And if you have mutations in this, then your regulation of iron is all off and you actually absorb too much iron. All of this leads to too much iron and hemochromatosis. Okay? Now, women present later. They always like this fact. Women present later. Why is that? Because they have their menstrual cycle. So they kind of bleed and kind of lose some of that iron naturally. So women present later. Women present later. But if a patient comes in, has cirrhosis, has bronzing of the skin, they might ask you what labs you want to order. And the labs you want to order is going to be all about iron. So ferritin is a big one. Ferritin checks for the storage of iron. And if you have too much iron, then ferritin is going to be way up. Your storages are going to be way up. TIBC. If you haven't done heme yet, you know that ferritin and TIBC are inverse of each other. If one's up, one's down. TIBC is binding capacity, what binds iron. And if you have too much storage, too much iron, your body will tell itself, I don't want to bind anymore. I don't need anymore. So TIBC will be down. You might even biopsy the liver and see iron. You might see the bronze or brown pigment. Here's an important fact that you should know. Brown pigmented cells in any of your body parts can be normal. It can just be wear and tear cells, lipofuscin cells. If you biopsy like a 90-year-old man's heart, it's going to be brown all over because those are just wear and tear cells. So how can you tell the difference between wear and tear cells and hemochromatosis? Well, you can stain them. This will be positive with Prussian blue. And you can say, oh, it stains with Prussian blue. It's iron, and it's not wear and tear. How do you treat it? Chelate the iron, get it away. And all the chelator agents are called defer. They all start with defer. There are a few exceptions, but defer is a big one. Those are all your hereditary liver diseases. That's quite a mess. I'm gonna finish this video off by talking about liver neoplasms. Liver neoplasms. By far, the most common is going to be hepatocellular carcinoma. Main causes of this, any cause of cirrhosis, any cause of constant cell turnover, causes damage, will cause this. So all the things we talked about, alcohol, hepatitis, especially hepatitis C, because hepatitis C is more chronic. You can have carcinogens, like aflatoxin. That's the toxin made by aspergillus in grain. And that just mutates p53, so that can cause it. That's a big one, they like aflatoxin. And the history, we'll talk about someone with long-standing cirrhosis. All right, so ascites, maybe have some varices, some spider nevi, all that good stuff. And then suddenly they take a dive. Their condition deteriorates. Yeah? Maybe they have increased or worsening ascites. Maybe they have worsening weight loss. Maybe they have a very enlarged hepatomegaly. So their condition takes a dive. Condition worsens. And then you know, okay, I'm dealing with cancer. And then how do you check? Well, you can do a CT MRI and you can see that mass. Sometimes they might ask you what lab you might want to look for. And you say, is there a lab specific to cancer or liver cancer? And there's not. However, there is one that they do just to kind of monitor it, and that is alpha fetoprotein. Kind of monitors its treatment course. All right? That is the most common liver cancer. Now there are a few less common ones that they want you to know. So let's just talk about these here. You can have cavernous hemangiomas. Now cavernous hemangiomas are benign, and you can judge by name. Hemangioma is going to be due to blood vessels. And these are cancer of dilated blood vessels. Dilated blood vessels. One of the things they absolutely want you to know is do not biopsy. It's benign, so you're not really worried. And if you biopsy, then you can cause hemorrhage because it's nothing but blood vessels. So do not biopsy. Second one, hepatic adenoma. Judging by the name, is also benign. And this is due to things like OCP and steroids. Why? I'm not quite sure. But it is avascular, so you can biopsy if you want. They'll give you a history of the OCP is easy. It's just be a girl taking OCPs and then develops a liver mass. All right, hepatic adenoma. Or steroids. Every steroid question I've ever gotten was they'll talk about an athlete, a wrestler, a football player, a bodybuilder. That's their code for a steroid user, and then develops a liver mass, hepatic adenoma. All right, so you can resect it if you want because it is avascular. And then last but not least, angiosarcoma. Angiosarcoma, judging by the name sarcoma, it is malignant, unfortunately. And angiosarcoma is related to carcinogens. One of the big ones is arsenic, which can be found in water, and also pesticides. And if you have an overdose of arsenic, one of the signs, physical finding signs, is almond breath. So your breath smells like almonds. Another carcinogen is vinyl chloride. Vinyl chloride is seen in pipes and plastic. So if they so much as mention someone's occupation, maybe they work in pipes, maybe they work with plastic, then you're thinking of angiosarcoma of the liver. All right. Those are all primary liver tumors. Now, secondary metastasis to your liver is more common than primary, and I shouldn't have to tell you, but how do you differentiate primary and secondary mets? Well, mets, you always have multiple nodules. So all right, if you have mets to the liver, you'll know because you have multiple nodules. And that is liver pathology. Hope you enjoyed. Hope we clarified some things. Thanks.